Live. I'm Brad Goodman. Once again with Dr. Randy Cron. I'm at UAB in the children's area. Randy, thank you for doing this again with us.
Yeah, sure. It seems like forever ago.
And it's been about what, 4 or 5 months. And when we first talked, that might be a good place to start. So Dr. Cron is a pediatric rheumatologist, and your specialty is with immunology. And within that realm of immunology, you have a particular research interest in cytokine storm syndrome. And cytokine storm syndrome is why people die when they catch COVID.
I think for a lot of patients, for sure.
And so why don't we just start there? Let's just sort of refresh us in terms of cytokine storm syndrome.
Yeah, so a colleague of mine, Scott Canna, generated this figure for an overview paper about cytokine storm syndromes. And cytokine storm syndrome is kind of an umbrella term under which there are multiple other named entities, including something called macrophage activation syndrome, or MAS. I guess that one's here. And we see that with certain rheumatic diseases like Still disease or children with systemic juvenile arthritis. But there's also malignancy like leukemias and lymphomas. You can develop a cytokine storm with that, or even with the treatment for that, like cytokine release syndrome is another term that's associated with patients who get CAR T-cell therapy, which you may or may not have heard of, for patients with refractory leukemia. But there's this large circle of viral triggered cytokine storm syndromes, including now what we think are COVID-19 cytokine storm syndromes, both in adults who get the COVID pneumonia and in children who get this, what we think is a post-infectious. It shows up maybe 4 to 6 weeks after an infection with the coronavirus. It goes by multiple names. We have listed here MISC, which is a multi-inflammatory syndrome of childhood.
So this specifically is some sort of trigger to the macrophage in your immune system.
It triggers not only the macrophages, but your lymphocytes get involved as well. It's just an overly exuberant immune response. So normally you get an infection, for example, you want to mount a response to that and hopefully clear the virus. But in subsets of patients, they have an abnormal or overly active immune response that's actually detrimental. So it can start clearing the virus, but often actually has trouble doing that if they have a defect.
So we just did a show on allergy. How does people with like various allergies, how does that relate to?
Yeah, fortunately that doesn't seem to affect. They don't seem to be any, I think, worse off than anyone else with this. Allergy, they have like an atopic response and what we call a Th2 cytokine response, but it's really a subtle or not so subtle defect sometimes in the pathway where certain types of white blood cells or lymphocytes kill infected antigen presenting cells that are presenting the virus to the immune system, and they have a defect in killing that cell. So number one, the virus continues to replicate, and number two, they interact for longer than they normally would, and that interaction leads to these pro-inflammatory hormones of the immune system, or cytokines, and those, when they're too high, cause multi-organ failure and ultimately can lead to death.
So the only sort of analogy to allergy is they both are involving the immune system, but with COVID, it's sort of a different aspect of the immune system that becomes overly responsive. Is that?
I think that's fair to say.
Fair to say. And you've got a graph at the bottom. Is this one down here?
Yeah.
What is that trying to show us?
Yeah, that's showing this defect in the ability to kill. So you have certain types of white blood cells or lymphocytes. There's two types, one called natural killer cells or NK cells, and another called cytotoxic CD8 T cells. And when they recognize another cell in the body that's been infected, for example, with the virus, they try to kill that cell off. And they do this by this pathway that involves a protein called perforin, which actually punches a hole in the cell. But you can have a defect in perforin, that protein itself, or a defect anywhere in this pathway that allows perforin to do its job. And if you have a defect or a partial defect in that pathway, you don't kill the virally infected cells, so the virus continues to replicate. But more importantly, in terms of the cytokine storm, they talk to each other and they spit out these cytokines, and they spit out way too much of them, and that's what leads to the multi-organ failure in the patients.
So, and then the biggest problem with this is, most people who catch this are asymptomatic, the vast majority. But we can't really predict, per se, who's going to have this cytokine storm problem. And what I recall from last time is that there are certain patients that are at higher risk, let's say the elderly, diabetes, hypertension, previous respiratory problems. But the people that are at the risk have some sort of genetic abnormality that also gets triggered, let's say environmentally, by a virus or something like that. I think that's this one right there.
Yeah, this is a combination, kind of an overview of what we were just talking about. And so you're right, there are certain conditions that put you at higher risk of doing poorly if you get the virus. Obesity, old age, diabetes, hypertension, chronic lung, kidney, and heart disease, just to name a few. But on top of that, like you're saying, there are likely, and we don't know for the coronavirus yet, but I would predict some of what we know for other cytokine storm syndromes, the genetic defects are probably present there. So if you have a genetic propensity for this, then you can get pushed over the edge pretty quickly compared to someone who doesn't.
So, but how could we possibly test for the genetic propensity, or why can't we test for
Well,
that?
we can. It's just it's not readily available, and we don't at this point know which genes to look for at this point for this particular cytokine storm associated with this coronavirus. There was just a report out the other day that a protein called TLR7, which is important in your kind of early immune system, your early detection system, was defective in a couple families. It's an X-linked chromosome, so the males in that family were more affected. They had mutations in this gene. So that's a start, and I don't know if that will hold up, but it was an interesting report. And then whether some of the genes that we know to look for in this pathway show up, time will tell, although a colleague of mine in New York has been studying the genetics of patients with this MISC entity, which is the one that the children can get that seems to be a post-infectious process. And she's identified some of these same genes and a novel gene that we've been studying as well, that at least by sheer numbers of mutations seem to be hinting at this pathway as well.
So we've hit every graph but the top one. So what's the top one about?
The top one is how maybe best to treat this SARS-CoV-2 virus. And like you said, 35, maybe even 40% of individuals in general get no symptoms at all or very mild symptoms. But 1 in 5 or 20% of individuals seem to get really, really sick with this virus and require hospitalization. And so early on, the old part of your immune system, the innate system, like your neutrophils and your macrophages, they go to work really quickly to try to start dampening down this virus. And a lot of people who get sick will say that for the first 3 days or so, they feel kind of miserable like the flu. And then for a couple of days, they actually feel better. Mm-hmm. And then they get really sick. And so this is where we really want to intervene to make sure that they don't die, for example. And at this point, your adaptive immune response, your lymphocytes, your T cells and your B cells is also kicked in. And so we can target this inflammation at this point without probably making it, the virus has probably done a lot of what's damage it's going to do. It certainly can do more. And it's probably replicated to a large degree by that point. So we can use things that may potentially make it harder to treat the virus, but more importantly, to dampen down the body's own response to the virus so that that's not what kills you. And so this is where this inflection point where you want to start treating whether it's dexamethasone, which came out of the big recovery trial out of the United Kingdom, or some more targeted approaches like blocking proteins like interleukin-1 or interleukin-6, for example. But early on is probably where you want to be treating the virus, like with remdesivir, for example, the antiviral agent that's shown some benefit for treating this. And there's also thoughts of another inflammatory protein, interferon type 1s, like interferon alpha or interferon beta, may be useful. This is still speculative, but there's some data to support it may be useful early in the disease, but more harmful late in the disease. So there's really a timing of how you want to treat. You want to treat the virus early, but you want to treat the immune response later.
So when we met here 4 months ago, we talked a lot about treatment, and steroids was one of the things that at the time, because I inject a lot of steroids for other problems, and we didn't know if it was good or bad, or where are we at with dexamethasone? Is it a timing issue? Because if somebody doesn't have COVID and you give them dexamethasone for a therapeutic purpose, would that then make them more susceptible to COVID or not?
Yeah, so in general, a lot of the drugs that we use to treat like rheumatic diseases, like arthritis, for example, haven't shown those patients to be at increased risk, with the exception of corticosteroids. Most people aren't on dexamethasone, they may be on prednisone, for example.
But that would be by mouth. But if
Right.
they came in for a shot in their back or a shot in their shoulder, they
Yeah.
might get dexamethasone.
Yeah, and that will go somewhat systemically, but that you're talking more of a targeted treatment there.
Correct.
But in general, corticosteroids are going to be tough to fight the virus if you give them early. And so both the recovery trial and even some studies after that, which showed that a marker of inflammation, the C-reactive protein, that those patients who had high C-reactive protein, suggesting they had a lot of inflammation, benefited from corticosteroids or glucocorticoids, whereas those who didn't have inflammation, low CRPs, actually fared worse. And so that's kind of in line with what the recovery trial said, was that if you had an oxygen requirement, which is probably a marker, indirect marker of inflammation with the acute respiratory distress syndrome, you did well with corticosteroids. Whereas if you didn't have an oxygen requirement, you didn't do as well.
Gotcha.
So it's
So
not only
still,
a timing,
it's still
but
a
it's
little
a
bit of
patient
it's still a little bit of
population.
an art here as far as dexamethasone goes.
Oh, for sure.
So I hate to admit this, but Facebook is also one of my sources of the news. And today on Facebook, there was a lot of chatter about, once again, hydroxychloroquine. And for, when we first met here 4 months ago, I got the feeling that we didn't know whether or not it was helpful or not, but I think you lean toward it's probably not going to prove out. And then my understanding is it didn't prove out, but now it's coming back again as a treatment. That in combination with azithromycin, I believe, and zinc. Azithromycin and zinc. So where are we on the hydroxychloroquine, the malaria drug, the Z-Pak, the zinc, those type of therapies?
Yeah, so there's been a fair amount published already, and for the most part, it hasn't shown benefit. There's some suggestion that in certain patient populations it may cause harm, particularly in combination with azithromycin because of its effects on heart rhythms, for example. We don't generally see that on its own because a lot of adult patients and even pediatric patients with rheumatic diseases get Plaquenil or hydroxychloroquine. But in general, it hasn't really borne out to be much of an effect, and that was kind of what we were thinking early on. There may be some benefit, and this is where I think some of this new information is coming on, prior to hospitalization. But that is still pretty questionable.
Gotcha.
But there are a lot of clinical trials out there, but some that have resulted already have basically said it's not helpful and it may cause some harm.
Okay, so if you had COVID, okay, you would start with, is it remdesivir as an antiviral?
I mean, I think...
Take me through how you would treat
Yeah.
yourself, Randy.
Yeah, so if I was sick enough to be hospitalized, so that's
Okay.
number one. If I wasn't hospitalized, I wouldn't be doing any of this stuff.
Okay.
I would just write it out and suffer it out at home, have as many symptoms as I do or don't have. But if I was sick enough to need respiratory support, i.e. oxygen, then yeah, I would ask for remdesivir. It didn't prove to be helpful in terms of mortality. There was a kind of a trend there, but it wasn't statistically significant. But it did show that it lowered your hospital so far, as best we can tell. So yeah, I would use remdesivir. It's going to fight the virus. But really the more important thing is to treat your hyperactive immune response. And if I had evidence of a cytokine storm, i.e. maybe my C-reactive protein is elevated or my serum ferritin is elevated, some of these markers of inflammation, then I would probably start with anakinra, which is this IL-1 receptor antagonist. There are anecdotal case series showing that it improves mortality. We have a lot of experience with it with other cytokine storms. It's really an overall safe drug.
Is it available?
It is available.
Okay.
Not necessarily everywhere. This isn't going to solve the planet's problems.
Okay.
And then I also strongly consider a corticosteroid. It doesn't have to be dexamethasone. That's the one that's been best studied in terms of the randomized trial, but I think any of them that have glucocorticoid effects are going to be beneficial. And then having to know the timing of that and the dosing of that is unclear still, but maybe a moderate dose of glucocorticoids is what I would use. So those that three-pronged approach. If we learn early on that interferon beta is important prior to hospitalization, that would be something else. But in terms of hospitalized patients, I think the remdesivir, anakinra, potentially tocilizumab is another one of these targeted approaches, and maybe a moderate dose of a corticosteroid like dexamethasone or methylprednisolone.
So it doesn't seem like we're really that much farther 4 months later. I mean, it
I
seems
think we
like,
are. I mean, I think
what has changed in 4 months in terms of the way you would treat yourself, really?
I mean, I had these biases already. So
Sure.
I had my
Okay.
biases that anakinra was going to work and that corticosteroids were going to work back in March.
Okay.
So that hasn't really changed for me, but I can tell you that clinical practice, particularly at the university, has changed, where they didn't want to have anything to do with corticosteroids, glucocorticoids, and then when the Decadron story broke, now most all their patients are getting that if they have evidence of a cytokine.
And then what
storm.
about the blood thinners? Aren't people getting like blood thinners? Tell us a little bit about that.
Yeah, there is a lot of clots, microthrombi, for example, that appear throughout the body in a lot of these patients, and there's some good blood markers like D-dimers, for example, which suggest that there's a coagulopathy. There does also seem to be a problem with the endothelial vessels that line the blood vessels. And so if you have markers like high D-dimers, for example, then a lot of patients are getting placed on low molecular weight heparin to help prevent some of these clots. And then
I know this really isn't up your alley, but testing. Can you tell us a little bit about testing, and kind of curious about false positives and false negatives and that. Do you have any comments about testing?
Yeah, so I think testing is really, really important, particularly at a population level. Like the Germans and some other countries have done a really good job of testing large groups of people, tracking them, tracing them, and isolating people who are sick and keeping it down at a population level. For individuals, there are the PCR-based approaches that typically are deep nasopharyngeal swabs, and then they send that sample to the lab and amplify the virus itself. And those tests are good. They're very sensitive. There is some suggestion that up to 20%, even if you do a good swab, can be falsely negative. But for the 80% you detect, it's still good at the population level of trying to cut down exposures by letting people know they have the virus, for example. For the individual patient, I've heard many, many stories of people coming in with fever and kind of this whiteout lung on their imaging that's highly suggestive that they have the coronavirus and other labs and whatever, and they had exposures, and yet they test negative. And they test negative 2 or 3 times, and then on the 4th time they test positive. So a negative test doesn't completely rule it out, unfortunately.
What about the fact that if you're positive and that the prevalence is so low that false positive can be quite high.
I'm not sure that's the case. I don't think there are, I think it's more of a problem with false negatives. I'm not, like you said, an expert in this field, but I think the false negative rate is a bigger problem with at least the nasopharyngeal swab PCR assay.
Okay.
The other assay is antibody, which tells you you've been exposed to it at some point. And a lot of the children who get this MISC phenomenon, some of them still test positive by the PCR assay, but most of them will test positive by the antibody assay. And there you can have more false positives because it may cross-react with other prior coronaviruses or other organisms that you may have been exposed to.
So that would be the blood test?
That's the blood test.
Okay.
David asked, what about inhaled cortisone steroids like is it cyanide for CSS in COVID?
Yeah, I don't know. There probably are trials, I should know this, whether they're inhaled steroid trials. I don't know of any data suggesting that they do or don't help at this point, but it's certainly a possibility.
Where are we headed with this? Can you get your crystal ball out for us? And because you know, it's like we had the period of where everybody was sort of quarantined and trying to suppress this, and now things are in many ways sort of, you know, baseball is back, let's say, and
unless your team tests positive, right?
Right.
So
schools are sort of kind of reopening. Colleges are going back. Where are we? Get your crystal ball out for us.
It's a loaded question because there's unfortunately politics involved here, and at a population level, I'm really concerned for this country, and for a lot of countries for that matter, but in particular the one that we live in. And I'm afraid when school starts back, within a month or two, we're going to decide that was a really bad idea, because kids will get it and they'll share it, but they're going to share it with everybody, right? Grandma, grandpa, parents, whomever. And it's just, I think the virus will take off just like it has when you open up bars, for example.
Mm-hmm.
Sports, you know, we're already seeing some baseball teams having to shut down for a while because, you know, this virus is highly contagious. And I do think we need to take the example of countries who have done decent jobs with this. Most, you know, in Western Europe and some parts of Southeast Asia have done some really tight control.
Now, didn't Sweden go the opposite way? Didn't they just say,
they regret that, I think.
Do they?
I think they do. They wanted to get this herd immunity, but too many people got sick too fast, and, you know, people die. And ultimately we want to prevent as many deaths, I think, as possible. You know, I understand the economy is going to sink, but if you're in a chronic state like we're in now, our economy is never going to recover. If people are dying all the time and we're being overwhelmed. And I only see it getting worse, particularly when school starts back up.
Well, I think that's when I'm going to want to talk to you again. Randy, I appreciate you taking the time. Are there any more questions out there?
That is it.
That's it?
Yep.
Perfect. Thanks, Randy.
All right, sure.
Thank you so much.